So I think we'll just wait 2 more minutes until it's 11:30, straight up or straight down, and then we'll get started. Good morning. For those of you who already logged in, we're just waiting maybe another 30 seconds to give all an opportunity to complete the connection. Good morning. My name is Gretchen Wartman. I am Vice President for Policy and Program of the National Minority Equality Forum and Director, excuse me, of our Institute for Equity in Health Policy and Practice. Our policy briefing today will focus on the opportunities the All of Us Research Workbench presents to community-based clinical researchers, in particular, those who are interested in engaging in research that can improve healthcare outcomes for populations that have been under-included in health services research. I am joined today by Dr. Shanta Whitaker and Dr. LaTasha Seliby Perkins. Dr. Whitaker is Senior Vice President of VIN Strategies and a Managing Director of Continuum Health Group. Dr. Seliby Perkins is Assistant Professor of Medicine at the Georgetown University School of Medicine. These two distinguished and accomplished scientists will offer their perspectives on two related issues. One, the All of Us Research Program's progress in fulfilling its mission. And two, the potential of federally qualified health centers through engagement with the All of Us Research Program to advance constructive inclusion of historically minoritized researchers and research. To set the stage, I would like to take a few minutes to provide an overview of the All of Us Research Program. The National Institutes of Health, through the All of Us Research Program, seeks to gather health and lifestyle data from 1 million or more US residents to inform a longitudinal cohort study that will be operational for at least 10 years. All of Us, which entered our consciousness as President Barack Obama's Precision Medicine Initiative, is an effort to enable more precise research that can lead to more effective therapies and thus reduce patient risk for ineffective or less than ideal care. The funding for the All of Us Research Program, up to $1.5 billion over a 10-year period, was authorized in 2016 by the 21st Century Cures Act. Of particular interest to the National Minority Equality Forum was the objective articulated by NIH Director Dr. Francis Collins that at least 70% of the participants in the All of Us Research Program would represent American residents that are historically underrepresented in biomedical research. These populations include, but are not limited to, ethnic populations other than white non-Hispanic males, LGBTQ+ individuals, women of color, and individuals who reside in rural or non-metropolitan areas. The All of Us research program is a pathway to mitigating patient risk by eliminating barriers to inclusion and the creation of new knowledge that will support new science, that will establish the foundation for the precision and the innovation that is needed to meet the needs of populations and conditions for which there are currently no approved, efficacious, or safe therapies. Simply put, the All of Us research workbench has extraordinary potential to reduce patient risk, to create opportunities for under-included researchers, to redress inequalities in inclusion in research for excluded families and communities, and to enable measurable improvements in the outcomes of healthcare for all American residents. But there is still a lot of work to do. Our discussion today is intended to open the door to an articulation of real or perceived structural barriers or other hesitancies that may impede the All of Us research program's constructive engagement with community-based researchers. Dr. Whitaker and Dr. Seliby Perkins will share their perspectives and are open to addressing any questions you may have. Throughout this briefing, please enter your questions into the Q&A box. The Q&A box, not the chat box. We will attempt to answer as many of your questions as possible after both presenters have completed their opening remarks. And yes, I have a few of my own as well. Dr. Whitaker, I'll now turn the mic over to you. You have the floor.
Thank you so much, Gretchen, for the warm introduction. Outside of the roles that Gretchen shared with you, I'm also an engagement counselor for the All of Us research program. It is my job to help organizations like NMQF have the tools and support necessary to educate their communities about the All of Us research program and the benefits of the All of Us data set. The mission of the All of Us research program is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. There are 4 main objectives: to nurture relationships with 1 million or more participant partners from all walks of life for decades, to deliver the largest, richest biomedical data set ever, making it easy, safe, and free to use as possible, to catalyze a robust ecosystem of researchers and funders hungry to use and support it. And lastly, to build and maintain a strong All of Us team capable of achieving the program's mission. The All of Us data set is one of the largest and richest data sets of its kind. As Gretchen mentioned, the goal is to get 1 million participants that are traditionally underrepresented in research. And I know what we're seeing too with the clinical trial diversity piece, that also is a factor there. So thinking about those, as Gretchen mentioned, that are underrepresented, racial ethnic minorities, socioeconomically disadvantaged populations, underserved rural populations, sexual and gender minorities, those who are living with disabilities, and those who may be older because they're traditionally excluded from studies like this. And they're getting there. They're close, the All of Us program has close to 600,000 participants registered and approximately 117,000 who have completed the initial steps of the program, which involves consent to participation, agreeing to share their electronic records, completing the first 3 surveys, providing physical measurements, as well as donating at least 1 biospecimen to the biobank. So that's something like whether it's saliva or blood. Currently, the makeup of the data set, there's about 50% of participants, excuse me, that are from racial and ethnic minorities. Another 80% of participants are overall traditionally underrepresented in biomedical research. The program captures a wide variety of data types. So there's survey responses, there's physical measurements, there's biosamples, there's electronic health records, there's genomic data, there's data from wearables such as Fitbits, which is accelerating research breakthroughs. It's a longitudinal data set that follows participants as they move, age, get sick, and try treatments. 3 years ago, the All of Us Research Program launched the beta version of the Researcher Workbench. This Researcher Workbench is a centralized, secure, and cloud-based platform that allows researchers across a wide range of settings and institutions at all stages of their careers, from young scientists to those who are more seasoned, to execute rapid and hypothesis-driven research with just a computer and an internet connection. The Workbench also facilitates equity and access in a deliberately inclusive way by creating a demographically diverse researcher cohort. Instead of granting data access by project or question by question basis, the program uses a data passport model to give registered researchers access to all the data on the platform for wide-ranging analyses. The Researcher Workbench also connects researchers to engaged participants who may participate in future auxiliary studies. The goal of the All of Us data set is to enable researchers to make associations through an integrated data set by cross-referencing biological data with data related to participants' environment and life circumstances. Currently, any US-based academic, nonprofit, or healthcare organization can enter a data use agreement as the first step of accessing the curated data set. And there are 3 levels to which a person can access this data: the public tier, the registered tier, and control tier. The public tier contains only aggregate data, and you can view publications that have been as a result of this All of Us data, as well as data snapshots. So it's a good way to search. So like, for example, if you have a research question that you might want to answer, maybe I'll use, for example, hypertension. You can easily use the public tier to see if they have the data that you may need to answer the questions that you're trying to answer. There's also a way for you to look at the survey questions that are asked of participants, as well as current research projects. I find it very interesting because there's over 2,000 projects currently being undertaken at the moment, and quite a few of them have resulted in peer-reviewed publications at this point. The registered tier is the second level tier of access to the data, and people whose organizations have that data use agreement in place that I mentioned earlier can then apply as individual users to access this level of protected data, which involves electronic health record data, survey answers, and physical measurements. The control tier contains individual data on a genomic data, as well as more granular participant data. This is a very secure level. You have to have additional security in place. There's a lot of things that you have to go through to get access to genomic data. And there are new data and tools being added all the time. So like last year, for example, they added in a social determinants of health survey that is really interesting. Currently, there are about 4,250 researchers that are using this one-of-a-kind data set to improve understanding of health and disease, identify opportunities to reduce disparities, and enable more precise approaches to care. So examples of researchers that are using this data set include biostatisticians, data scientists, early career researchers and students, epidemiologists, geneticists, health equity and health researchers, And also, interestingly, one thing that the program started doing more recently is they have a researcher day where students who are either at the undergraduate or graduate level can present their research that they're doing within the All of Us data set. And there's also a science day for those who are doing research who are further along in their career. So more of the earlier investigator or established investigator can submit an abstract and be potentially selected to present at Science Day. So it's a great way to highlight some of the research that is ongoing. And both Science Day and Research Day are coming up in a few months. So it should be very exciting to see the students' work as well as some of the early investigators' work highlighted. So the program is working to make this data set more accessible to a diverse group of researchers. They've been inviting feedback from researchers across all settings and career stages. They've been applying recommendations from a diverse steering committee, including experts from various backgrounds and communities. They've been exploring opportunities to support team science through a collaborative and accessible cloud-based platform. And they've also been seeking new ways to enhance accessibility and access by working with a wide range of organizations. So historically Black colleges, Hispanic serving institutions, and other smaller institutions that may not normally have access to data. They've also been doing their best to promote a responsible and ethical use of data. Again, as I mentioned, to get access to the data, you have to go through a data use agreement process, as well as you have to go through ethics training. Since last year, the All of Us program has been returning personalized health-related DNA results to participants, with reports detailing whether participants have increased risks for a specific health condition and how their body might process certain medications. I think probably one of the funniest pieces of information that came back to participants was whether or not they have the ability to taste cilantro. I thought that was funny personally. I thought those were pretty interesting. Just the variability in people's tastings of cilantro. I didn't realize that some people really taste the cilantro and some people taste it as something else. And for me, cilantro is great. So it was interesting to learn that little fact. And so All of Us is also collaborating with organizations and associations with a robust body of researchers traditionally underrepresented in biomedical research, and sharing information about the All of Us data set. So for example, as I mentioned, earlier about just trying to increase the diversity of users, currently there are about 29 historically Black colleges and universities that have data use agreements in place, and there are about 36 Hispanic serving institutions that have data use agreements in place. And we know diversity is more than race and ethnicity. So communities such as those living with disability, those with differing socioeconomic statuses, women, sexual and gender minorities, older people, surprisingly, once you get to a certain age, you tend to be overlooked, but they're being included in this data set. And so it's very exciting to have the ability to study, diseases that are found as you age. And while there may be some advantages, I talked about a lot of the advantages, there are some limitations to this data. Right now, there are only 2 statistical packages that you can use with the data, R or Python. And I know for a lot of folks, especially public health folks who have been trained either in SAS or Stata, like I have been, can find it hard because then you may potentially have to try to learn a statistical package or find a researcher who has the ability to code in R or Python. And I know the program is working on this because this is definitely something that researchers have expressed already. Another thing that usually gets asked about the data is it protected? And yes, the data is very protected. There's a data warehouse that houses the data that is built with the most advanced security available. Security is rigorously tested, as well as researchers themselves have to agree to a code of conduct before accessing the data. And then lastly, I would just say, I recommend everyone, in addition to what Laka shared in the box about Join All of Us, I would also recommend checking out researchallofus.org to learn more about data sources and methodologies. And then on that same page, you can look at the research projects directory and spotlights to learn more about the research in progress, as well as how other researchers are using the data set. And I'm happy to take questions at the end, but just wanted to give that high-level overview of all of us, as well as the researcher workbench and the data.
Thank you, Dr. Whitaker. Dr. Seliby Perkins?
Dr. Whitaker did such an amazing job at giving all the data about all of us. And so my role here today is to tell you more about, as a physician, for those providers out there, how you can use it and why it's such an amazing tool that we should be happy to be a part of and to learn more about. If nothing else, learn more about. And you're starting by being here today. So thank you all for tuning in to learn more about the All of Us project. One thing Dr. Whitaker did highlight is the 4 pillars of like all of us. If you are a physician or provider, a lot of times we don't think of ourselves as researchers, you know, where we may just think of ourselves like, I see patients every day. I'm not a researcher, or I have no desire to do research because I'm a primary care physician. I work in community health. And so you may think that research may not be a part of your job, but we practice evidence-based medicine, which means research is necessary, which means we should also be involved. Part of the things that we do with our patients is the same thing, the relationship building that comes with the All of Us project. We do that every single day with our patients. For that reason, it's important for us to sign up and learn more about the workbench because of that relationship and because of that rapport, the information that we use from the workbench is trusted. It's trusted because your patients trust you, your community trusts you as their, primary care provider or as their physician in general. And so you can think of yourself as a researcher because you are developing not only a relationship with the research data set, but that data set can be used as a tool to further and a better rapport with your patients, because you can answer their questions from a data set that also includes them. The delivery of data is important for you because of the everyday use that you could use it. There are multiple layers, like I said, of access. You can start with public, kind of ease your way in, and just like we use other sources to get information. What better source than a source that includes the population that you care for? I practice MSR primary care at Fort Lincoln, which is in Colmar Manor, Maryland, just outside DC and PG County. And the population that I take care of is the population that this data set is working to include. And so it's important that I deliver the type of data that makes sense for my patients. And the program is, all of us is trying to catalyze research partners. And every time you hear research, if you're anything like me, like I'm not a researcher, I don't know the special ways to look up and use data, but we use data every single day of our lives as we are building our team and our clinic, as we are making decisions for our patients, and as we are building our clinical team is looking to us to have be the most informed we can be. And there's no other data set like this. There's no other data set that includes the intersectionality that we've talked about with all the populations that you don't normally see in the clinic setting. You don't normally see on the research side. Is for the pipeline, for the early career student, for the early career physician, for mid and late career physicians. It's never too early. It's never too late to learn more about an amazing tool. And when you hear things like data use agreement and ethical training, if you're in academics, like we do that for your IRBs anyway. You do that in general anytime you join a clinic or start working at a hospital organization. And it's not scary, and the more you use it, the better you will get, because it is a tool for practice. The medicine is a practice and there's an art. And so there's tools that have to be used in order for you to be able to practice at a higher level. And so again, a good way for me, I say to start, with the public access. You can just use it to go to as you are trying to practice more about precision medicine. I don't know how many of you know about precision medicine, but it is for those of us, who are really working to be anti-racist physicians, anti-racist practitioners, knowing more about the entire global biographical or biological construct of the patient is by going through and having that access to a workbench like this one, because you're not thinking about just the social construct, but the actual biological data around a patient. You can use that to better serve them, and not just generally, but more specifically for that patient. And so having access to the surveys, and learning more about how to be the next level once you ease your way in and get registered. And then once you get to the control level, it's a community. And so it won't be hard for you to learn more about the data set, not be afraid to jump in and learn as much as you can. Because one of my other roles, in addition to being a family physician, is that I am an assistant professor at the School of Medicine, Family Medicine, and I run the community-based medicine course. And in the community-based medicine, we get med students out into the community to learn more about the community, because if you don't learn from the community, you end up doing things to the community instead of for them. And so we learn that early on in their medical education. But in doing that, you have to have the community partner to help learn more. But then you learn that research is not just, we call it the workbench, but it's not just a science workbench. It's also a community is a part of that workbench. The community is a part of the information that's necessary to have a broader spectrum, so that you can take the demographics, the region the person lives in, the weather that the person is exposed to, if they live near a highway, if they have asthma, all of those things. We learn our social determinants of health are also important when you're thinking about treatment for patients and tools for patients. And the All of Us project is focused on making sure that all of those elements which aren't traditionally a part of research, are. And so the workbench is an excellent tool that I highly encourage anyone who takes care of patients, anyone who doesn't take care of patients, but is interested in learning more and getting more information out there, to join the workbench, and at the very least learn as much as you can about it, and keep coming to these kind of forums to ask questions, to reach out to the Dr. Whitakers of the world, to learn more about what this bench has to offer and how you can use it successfully in your clinic or in your community or in your institution, or just in your daily practice as a scientist, because we all are scientists and researchers at some level. It's just a matter of accepting that and not thinking the research is for someone over there and not for me, that you need to jump in and be a part of it, because we are a part of healing our community and taking care of them. And so don't be afraid of the research word. You can become one as well, specifically if you're going to do it with this organization, learning more about the All of Us project. And I will stop there, because I feel like the information is there and there's some questions that we can get to. So I'll pass the mic back to Gretchen.
Thank you. And I do have a few questions for you, but I also want to open the door for the two of you to have a conversation among yourselves, because I would say that what I've heard from Dr. Seliby Perkins is something I hadn't thought of, which is that the individual physicians, or that the All of Us research workbench, presents an opportunity for the individual physicians to embrace the concept of themselves as researchers as well as practitioners. And I think that's extraordinarily important as we move forward towards creating a research delivery and financing system that is responsive to the information that's can only be gleaned by more constructive engagement with the communities who have not been served well. I guess my question for Dr. Whitaker is, in response to that, how is the workbench, or how is the All of Us research program designed to enable that individual physician to see herself as part of this research network? I get my question is, can they engage as individuals? Do they need to move? Do they need to engage through an organization or an academic research institution? what are the potential barriers or opportunities for that individual physician so that they don't become discouraged by what may appear to be insurmountable bureaucratic processes?
Great questions. I would say, so I work with 2 provider organizations that are very involved in the All of Us program and educating their respective clinical populations about the benefits of doing research using the All of Us data, as well as engaging just to learn about it, you know, because I don't think a lot of physicians out there, or a lot of clinicians out there do not really know about the All of Us program and the possibilities of the data. Currently, yes, the limitation is you have to be affiliated with an institution that has a data use agreement in place. I know they're working to broaden the access data so it can be accessible to those that are more of the community scientists. But currently the access is through an institution. And if a person's institution does not have a data use agreement in place, you can easily apply for a data use agreement. Sometimes that, just sometimes it will, you just have to go through that process, but definitely happy to talk to any clinician that might be interested in engaging with the data to help, give them some tips on how to navigate the process. And I do think, as far as like just thinking of themselves of individual data, I think one thing that COVID has taught us is that population health is extremely important. And while individual health, patient health is very important as well, sometimes, it's good for both clinicians as well as researchers to take a higher level view to understand what's going on in a population level. And so I think the data set, number one, for anyone who's on this call, who's ever did research with any government data set, they know sometimes you have to extrapolate for populations that look like us, that are on the screen, as well as other communities that are underserved because the data is just not there. They don't capture enough data of people who look like us. And All of Us has gotten that right. And I feel like that is a rich resource to tap into, to be able to ask those health disparities questions. And I'm hoping that physicians that are, whether they're associated with the institution or individual, definitely are ways to engage to access the data. I know associations, and most clinicians are members of associations. Associations can get access to the data and then can give their members access. So there's very creative ways to get access to the data, but I know the program definitely is working on the individual access piece.
I just want to highlight that part.
Dr. Seliby Perkins?
Yeah, sorry about that. I want to, like what Dr. Whitaker said, all providers and physicians I know about are a part of some some organized medicine organization. I myself am a member of the American Medical Association, the American Academy of Family Physicians, the National Medical Association, all of which you as a physician leader, if your organization is not a part of the All of Us project, you can bring it to them. There's such things as a house of delegates, or you can go to Mike and say, I want to make this, this resolution about why we should join. And because there's so much, what you're learning today, there's so much information out there that most organizations will at least consider something like this. And so those memberships that you pay to be a part of could also allow you to have access. And then you are listened to when it comes to your organization. The organization you work for usually values you and usually values your commitment and values your service. So even if it's going to the websites that are provided in the chat and just learning more and taking it to your chief medical officer and taking it to your next, the next in line regionally, to have it just a presentation of to learn more about it, because we have to spread the word. That's what we're trying to do today. And so don't let me mislead you saying it's only as an individual. What I'm hoping for providers and for physicians to think about is how you can get organizations to get that data use agreement, to do the ethical training so that you have access, because you can tell them this is a tool that I want access to based on the population that I take care of, so that I can use this as a tool. Because your organization, a lot of us have, information that we use day to day in clinic that we have access to that our organization pays for, so we have access to it. This is the new information that we need access to, and they will listen to you if you make that argument.
Okay, and this is excellent. I'm pleased to hear this from you, Dr. Seliby Perkins, because I would say since our first Thought Leaders Roundtable, when we pulled researchers, academics, and others who are underrepresented or underincluded together to provide input to the All of Us research program as it was moving forward, developing its operational plans. What we heard always in 3 different thought leaders meetings was that the key to success would be engagement of the community-based physician. And that absent that constructive engagement up front, a key inflection point in that systems loop that would enable not only the program to meet its enrollment targets, but also to complete that loop to move the knowledge development forward and improve the quality of care. The community-based physician was key. So I'm going to ask Dr. Whitaker, and I don't know if she's got an answer now, and I'm sorry I didn't anticipate this. One of the concerns we heard often, always, from the community-based physicians was that it's a great idea, but I have neither the time nor the staff to embrace that additional aspect of my work. And so what I'm adding now to sort of the list of under-included researchers is the community-based clinician. And what we can do is look at having future conversations about how to constructively engage with NMA, AMA, and others to make sure that those critical clinicians have opportunities to engage that are responsive to and sensitive to the business constraints, the business models that frame the work they do. So I don't know if Dr. Whitaker has anything to add regarding what may already be in place to support that community-based physician. And I'm sorry, I didn't see your hand up, Dr. Seliby Perkins. So Dr. Whitaker first, and then Dr. Seliby Perkins.
Sure. So one of the organizations that I work closely with is the Cobb Institute, which is basically the think tank branch, the research branch of the National Medical Association. Their fearless leader, Dr. Randall Morgan, he is a community physician at heart. He's an orthopedic surgeon, and he is definitely one to tell you, I don't know how he does it. It just has, he has his hands being pulled in all directions. I think in the case of a person who's busy, and this is not just clinicians, it could be someone who else is a public health researcher who may have like a whole different agenda. I think the collaboration piece will probably be a key thing, that one person doesn't have to do it all themselves, that they can find a group of people that are working or interested in the same area of interest that they may be interested in, and work with, maybe that partner might have a researcher that has the time, that has the availability to actually do the analysis, because the analysis piece is the piece that can be the time suck between coding and having to then, analyze and do regressions and all the other lovely statistical things you could do with data. But I think like the partnership and collaboration can save you. I will say myself, for a paper I had published a few years ago, and I was working a crazy full-time job, wasn't in academia at the time, and was able to collaborate. It was a multifaceted collaboration. So we had someone from GW, we had somebody from my firm that I was working with at the time, and a whole bunch of other researchers that came together to take little bits of the paper. And we were able to get it accomplished because, I feel like sometimes you might have to collaborate because you can't do it all, especially if you're working in the community. It can be hard to just try to do a project all by yourself. So collaboration is key.
Thank you. Dr. Seliby Perkins.
Amen. collaborate, absolutely. And also learn more about your organization. I work for MedStar, and there's a community health, conglomerate part of MedStar that does a lot of community engagement. You can go to them and say, this is something that I think I want our organization to be, have access to, so that I can have access to this kind of information. This is the patient population, that our clinic takes care of. And this is the type of information we need in order to do our job and do our job well. As I'm in academics, but I am in a community clinic, so I understand the time constraint. But just when you see patients, every day that I'm seeing patients, I want to make sure that I'm giving them the appropriate treatment. So in between patients, I might look something up. I want to make sure it's the correct dose. I want to make sure that it's the best medicine, that there's no, recalls. You're constantly seeing patients, you're constantly doing research. So it's a matter of getting the tools and getting the access to that information. And so CME is also an opportunity for folks to learn more about, it can be a whole continuing medical education is necessary for you to continue with your license and practice anyway. So having a CME on all of us and learning more about what the data set has to provide, and also continuing to learn about best practices in the use of it. There's no excuse. When you decide to be a provider, to be a physician, you sign up to be a lifelong student. It is a part of your job. And so you have to make time to be the latest and greatest research. And what better place, okay, than the Workbench that includes the type of patients that we are, because we are also patients. Our families are patients, our communities are patients, and then there are patients that we take care of. So what better place to do that in a Workbench that has data for us, by us, all of us. And so you prioritize it in a way that makes sense for you, but know that, we're learning as we go, and there are things that we can do to make sure that we're learning as much as we can about the data set and learning how we can put that in our practice from day to day. And it can come from the top down, but even the very hard community provider can find some time to prioritize this in a way that makes sense for them.
Thank you. I'm going to turn a bit to federally qualified health centers and how we can, or how they can engage as a network to not only contribute to the success of the All of Us research program, but also, I think, sort of close that loop, Dr. Seliby Perkins, that you were speaking to, which is that bringing that framework of and the additional information that's available in real time and All of Us research workbench to their practices and community. And so I'll let either of you go first. One is, what needs to be done, or what can be done that, well, let me back it up. What needs to be done, or what is being done that most FQHCs may not be aware of, that sentence, to enable FQHCs to engage as organized medical practices. But also there's a question in the Q&A regarding whether FQHCs can somehow become sample collection sites to sort of facilitate that participant engagement with the All of Us research program. So do I start with Dr. Whitaker? Why don't I do that? Dr. Whitaker? No? Okay. Dr. Seliby Perkins.
Well, federally qualified health centers are a great way to collaborate, because there's a network, right, of federally qualified health centers. You have to meet certain metrics to get that title. And so there's a list of that. There are people, in collaboration was key in knowing that these are centers, these are medical homes where we take care of the most diverse populations. And so this is the kind of data that we need to be using to take care of them better. There are also things, to be a federally qualified health center, you have to have an interdisciplinary team. So we talked about earlier, the community provider that's out there on their own, they may not have the same kind of team that a federally qualified health center has, but they could use the data from that health center. And so like Dr. Whitaker said before, you want your organization to get the access. You want your organization to be a part of this. And so there is ways to have a federally qualified health center be a part of the All of Us program, and then collaboration can happen from there. If you're seeing some trends in your region, if you're seeing, if you want to focus on, Black maternal health in your region, this could be a tool that could be used. So those medical homes, those health centers are a fantastic place to start that can be a part of the All of Us program because of what the data set is about and who the data set is supposed to be for us and for our populations.
Thank you.
So I can answer. I was looking up because I was trying to make sure before I spoke wrong, that I was right about a federally qualified health center that's actually participating in the All of Us program. So Mary Center, which is based in DC, is a federally qualified health center. They do education and awareness of the All of Us program. They also have partnered because there's different areas for different forms of collection across the country. So there's these thing called direct volunteer, where a person would get sent like a way for them to collect like a serum, like a saliva sample that they can like request a kit and then send the kit in, sort of like, I guess I don't want to, because All of Us is not like 23andMe, but you know how you have to take a sample for something like that and then send it off. It's something like that, where you can take your sample and then send it back to the All of Us program. I know Mary Center has done that. They've partnered with the DV market, which is called the direct volunteer market, to work with the partners that are on the ground here. So like Scripps, organizations like Scripps that have been that can then partner with a federally qualified center to do that work. So there are opportunities for federally qualified health centers to participate. There are ones that are doing it now, and they have a lot of I feel like educational awareness programs, and sometimes collaboration too is a big thing for a lot of the partners that work with All of Us program. So working with other partners to do a community fair where they can collect samples, working with known partners on the ground. So it might be worth just to the question, depending on where you're located, there are partners across the country that you could potentially pair up with that would then be able to do collection. Outside of that, I know when the program first started, they had requests for, they have these big requests for proposals for people to become dedicated centers. I'm sure as the program gets bigger, there'll probably be additional opportunities to apply for that kind of opportunity. But right now, I don't believe there's any opportunities for additional organizations to apply to be a collection center.
Thank you. There's a question, still looking through that community lens. Someone would like to request a presentation for local Black Nurses Association to not only be educated about or become better informed about the All of Us research program, but that would then enable that local Black Nurses Association to educate the community about the importance of Black community involvement in research, and that is safe and beneficial to do so. And I'm not recalling, Dr. Whitaker, but is the National Black Nurses Association a member of your network?
Yes, the National Black Association of Black Nurses is a member organization. So you could definitely reach out to the association itself. They have a point of contact there that would be able to either do the presentation for you, because everyone who's a partner is trained. So the Black Nurses Association, the National Black Nurses Association, is definitely one of the partners that has been with the program for several years at this point. So they are well versed and educated in this program and can definitely do a presentation on the All of Us program for you.
So I'm going to say, because I'm looking at some of the other questions for the—
Can I address that question real quick, Gretchen? Just real fast about the Black nurses. This presentation is for y'all too, okay? When we say providers, we say physicians. There's no line crossed. I work very closely with doctors and nursing practice, nurse practitioners in our clinic, our community-based learning medical students, they have nurses as their faculty team leads a lot of the time. And so you can send this to the local organizations as well. Though something special can definitely be done for the Black Nurses Association, there's no delineation on, only doctors can listen can learn from All of Us project. We all have one mission, and that's to make sure that our communities are taken care of in the most appropriate way. And so we can send them this if you want, or they can also, like you said, have something specific for your organization. Just like we listed off the American Medical Association, National Medical Association, Black Nursing Association is right there and with us and all other providers.
Thank you. And I think I would add to that the National Minority Quality Forum, in addition to having relationships with FQHCs around the country, also have relationships with health ministries in different communities, as well as hair care providers to enable information to, be presented, made available to community in other than the clinical or medical sites where we tend to be most of our days, other than in a physician's office. And I'm not saying that to assign higher value to one or the other. What I am saying is that increasing the number of communication channels in community regarding health research in general, but also I would say the All of Us research program is essential to the success of the program and the health of the community. And although I'll say it again probably before the end of this briefing, the infrastructure that has been created by the National Institutes of Health with public dollars is I won't say once in a lifetime, but a unique and a first opportunity in this country. And I'm not sure how it compares worldwide. And engaging with it through the different portals through which one engages can only serve to enhance the health of the community in the short and the long term. And so I'm encouraging people to communicate with us, communicate with Dr. Whitaker and others, to think creatively regarding how we can buttress, if you will, the All of Us research program and the All of Us research workbench to better meet our needs. And so I don't want to lose one issue that Dr. Whitaker touched on earlier, which is the way in which the All of Us research program was used during the COVID-19 pandemic to conduct a participant experience survey and to give us a sense of how those data have been integrated into the All of Us research program and maybe the workbench.
Sure. So there's the name of the survey, it's called the COVID-19 Participant Experience Survey Data. It's called the COPE study for short. And it was created to learn more about how the pandemic was affecting people's lives, particularly their mental health. And the survey included questions about social distancing, general well-being, mood, stress, and more. About more than 100,000 participants responded to one or more of the 6 COPE surveys that were administered between May 2020 and 2021. And I think, just to highlight just a few data points, 62% of participants said that they were bothered by sleeping problems, and another 53% said they felt nervous and anxious. And I think we're seeing still a lot of that now. Even if you look at the news, just some of the mental health, how mental health is becoming such a high priority. Senator Fetterman from Pennsylvania, who checked himself into a facility. And I know there's been a lot of conversation around mental health and what does it mean, as well as having that gender discussion where, you know, it's been seen that, you know, women, it's okay for women to have mental health issues, but apparently, you know, there's been a really big discussion around men having to be strong and not having these mental health issues. So that piece for the survey to me, just to bring it back, that piece of the survey to me around mental health is really interesting, because I really feel like the COVID-19 pandemic is still affecting people's mental health. And it really did when we first were having to social distance. And even with us now being able to interact more, it's still that, you know, trying to claim some sort of normalcy to your life when, you know, it's just that threat of disease is there for a lot of people.
Thank you. There's another question. Can healthcare consultancy companies have access to the All of Us platform? We conduct, they say, staff development training to healthcare providers that work in underserved communities, nonprofits, and create curricula for our staff training. So I'm going to give that one to Dr. Whitaker for a response.
I know there's some there's other, I guess it depends on the kind of consultancy organization. So right now it's not just academic centers that have access to the data or academic institutions. There are, you know, associations, as I mentioned, there are organizations like NMQF that have access to a data use agreement. But I haven't seen any like companies yet. Not to say that wouldn't be a possibility down the line, but I don't necessarily know if they've given any for-profit organizations access to the data at this time.
Thank you. Dr. Seliby Perkins, did you want to add anything to that?
No, and I think that's on purpose, because there is the data use and then there's the ethical training. And so making sure that whatever you're doing with the data is ethical and based on caring for the population. And so I think, you know, you would have to go through those steps anyway to see if your organization would meet the criteria to have access to said data. So Dr. Whitaker, you know, made a like a connection to possible, like, oh, you have 23andMe and how that works, but that's very different than the parameters that are put in place for all of us data set. And that's what she was pointing out, because once you get to that control level, remember, it's the access level, the registered level, and the control level, you know, you have to meet certain, just think of it like the security clearances. You have to have a certain levels of security and ethical clearance to be able to get access to data, because it is at the granular patient information level, and we take it very seriously to protect our patients and those vulnerable, having to be resilient populations that we want to be involved in the data set.
Thank you. While you are on, have your mic open, Dr. Seliby Perkins, do you have any specific recommendations or general recommendations for the All of Us program that might enhance the effectiveness of their outreach to under-included researchers?
I think the All of Us program is doing a great job right now. Like these webinars, having individuals like Dr. Whitaker available to answer the questions that would cause people to not want to engage, just like we saw back in the COVID-19 like vaccine hesitancy. People were hesitating because they didn't understand it. They didn't have the questions answered. They thought that some of their questions were silly, or they're just going to keep it to themselves. But having forums like this and having more forums like this are important for people to get their questions answered and to get the information out there for people to take away the mystique that you can't be a researcher yourself. You can't access this data and know how to use it, and there can't be collaborations that are done that you can use it in a routine fashion. So more of these forums, more, maybe a continuing medical education and best practice so that people have talking points when they go back to their organizations or go to collaborate with community partners on how an All of Us project, people can learn more about it and that how it can be used effectively.
Thank you. I'm seeing more questions that are different aspects of the same question, which is what do we need to do to access the All of Us research program? I would encourage all of our audience members who have those questions to use the links that have been shared and to reach out to Dr. Whitaker or directly to the All of Us research program to explore those opportunities, because I think what Dr. Whitaker and Dr. Seliby Perkins have been saying is, which is regardless of your point of departure, there's a process for gaining access to the data in the All of Us research workbench that's absolutely essential through the lens of data protection, participant protection, and credibility of the work that will be produced through the All of Us research workbench. And we encourage you to engage with the program and start that process. I'm not hearing a workaround for different kinds of organizations. You have to go through the process, and I will say that the National Minority Equality Forum went through the process, and it's a lot easier than we thought it would be. And the support team that's available to work with you is very responsive, and I encourage you to do that. I think I don't see any additional questions in the chat. Let me just check one more time. Excuse me, wrong thing. In the Q&A. So while we still have a few minutes, Dr. Whitaker and Dr. Seliby Perkins, I want to thank you for being so forthcoming on this policy briefing and taking so much time out of your day. As we close, what messages do you want to leave with the audience? I'll start with Dr. Seliby Perkins and then go to Dr. Whitaker.
In short, it's worth it. Okay, it's worth it to know about the workbench. It's worth it to find out the information, to educate yourselves, and hopefully get your organization or partner with folks to get access. And the any steps it takes to get there is worth it, because the populations that we are caring for, the populations that this information is for, historically we've had some hurdles, right? And so it's worth it to take whatever steps we need to take to ensure that this information is both protected and that it is diverse, and encourage, I've been saying providers and physicians and researchers, but our pipeline to be involved in you're our future, and for you to have this kind of data available for you is phenomenal. And so it's not too early to try to see if your institution will have access to this data set, so you can do your research projects if you are a student. But in a community of providers, though it may take an extra step and you may have to collaborate, or it may be something that you connect with when you connect with your medical or organized medical organization, is worth every step, because we practice evidence-based medicine anyway. And so what better evidence than the type that is precisely for the organizations and for the populations that we care for.
Thank you. Dr. Whitaker?
Sure. I think, the piece I would take away is just I would recommend checking out the data set, going to some of the links that Laka shared in the chat box. There's a wealth of information out there to give you a little bit more meat around, just the All of Us program. This program has been around for a long time. And as Gretchen mentioned, President Obama really spearheaded this initiative, coming to fruition. So I am really excited to see where this program is going to go. how, the data will be able to, answer some of the questions that we have remaining, especially in the health disparities and social determinants of health space. I'm just really excited to see, what the possibilities are with this research. And so just encouraging everyone to, just take some opportunity to learn more about the All of Us program, check out the Researcher Workbench, and consider, registering as a researcher, but also consider registering as a participant, because we do need more participants that look like us to participate in research and to be involved in the research process. I think there's just, a lot of data out there that they're giving back, especially with the return of information that they started last year. So it's a very interesting way to learn just a little bit more about your own health history if you're curious. So I would say that is what I want to add. And again, just check out joinallofus.org and researchallofus.org.
Well, thank you. I think what I would add to the comments made by both of you is that a step that clinicians, researchers, others can take to demonstrate support for the program is to enroll as participants, to bridge the gap between that researcher participant, those groups of engaged citizens, and think of yourself as beneficiaries of the research program as well. And I would say to participants who have trust issues with the system, that failing to engage is not a way to address the trust issue. The program exists, and the program will move forward based upon the information that's included in its workbench, constructively engaging not only as participants, but monitoring the outcomes of that research and thinking of your ownership of that, because I'm going to say again, this is funded by tax dollars, is extraordinarily important. The National Minority Quality Forum has been constructively engaged for 7 years, and if we're allowed to, we will be constructively engaged for another 7 years. And I encourage everyone on this call to find a way to be supportive of this extraordinary opportunity to redress health inequities in our society. And that being said, it's 25 minutes early, but also I'll give you all back 25 minutes. Thank you so much for joining us. There have been questions about whether there will be a video available of this webinar. My understanding is that our communications team does post all of our webinars on our YouTube channel. And if that link is available, or when it becomes available, we can find a way to make it available to everyone who participated in the audience and to others in our stakeholder cohorts. Thank you so much. Have a good afternoon. Bye-bye.